بسم الله الرحمن الرحيم الحمد لله رب العالمين والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه وسلم أجمعين. سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. اللهم علمنا ما ينفعنا وانفعنا بما علمتنا يا كريم. Dear colleagues, now we will continue the lectures of pediatric imaging, and we have started the imaging of the pediatric chest. We have finished with the normal anatomy and some of the techniques. Then we are going to the second part of the chest imaging in the pediatric patient, and this will deal with how to interpret the chest x-rays. And of course, we should follow a specific or an organized approach for interpretation of the chest, whether in the children or in adults. And this approach is consisting of three steps. The first step is to ensure an optimal quality radiograph, and this can be achieved if you realize that the patient is well centralized and the patient has a deep breath before being radiographed, and the radiographic factors are optimal so that you can see the details of the lung and the details of the costophrenic angles. And actually, these criteria cannot be easily achieved in the pediatric patient, but we'll try as much as we can to have a good quality radiograph. Number two is to have adequate clinical data about the patient in order to be able to achieve a probable, reliable diagnosis. And if you have the chance to have the previous films, this will be of much help. Then after these steps, if you did not reach a reliable diagnosis on which treatment can be given, then you should have the support of CT scan. Let us start the interpretation of the pediatric chest X-ray by looking at the chest, and we would like to differentiate between two main issues. The first one is, are you dealing with a focal lung pathology or you are dealing with diffuse lung disease? And this is an example of a focal lung pathology where you see a mass or a nodule, 2 or 3 in the lung, and the rest of the lung is free. While in cases of diffuse pathology, you can see that there is a diffuse process, diffuse lesion affecting both lung fields. And it is an easy task to differentiate between focal and the diffuse lung disease from the plain X-ray. Then, if you have decided that you are dealing with a focal lung lesion, what are the possibilities? We have 4 possibilities. Number 1 is a nodule, which is a well-defined lesion that is less than 3 centimeters in diameter. And the mass is a well-defined lesion that is more than 3 centimeters in diameter. And the patch is an ill-defined lesion with air bronchogram inside. And finally, the cavity, which is a well-defined lesion containing air either totally or partially. In this example, you see that the cavity is containing air fluid level, and if the cavity is totally containing air, it is also known as a cavity. And here are the focal lesions in the lung by CT scan. This is the nodule, well-defined lesion less than 3 centimeters in diameter, and this is the mass more than 3 centimeters in diameter, and this is the patch, ill-defined lesion with air bronchogram, and this is the cavity. Cavity containing air is a cavity. Cavity with air fluid level is also considered the cavity, and the cavity with a mass inside the cavity. And these are 3 different types of cavities which can be seen in the pediatric chest. Then starting by the pulmonary nodules. If you see a focal lung lesion and you have decided that you are dealing with a pulmonary nodule, what are the possibilities of pulmonary nodules in the pediatric patient? I usually try to achieve the differential diagnosis, eliciting here the common lesions seen in the pediatric patient. And in my opinion, we have these common nodules encountered in the pediatric chest: the tuberculoma, the hamartoma, the metastatic deposit, the arteriovenous malformation, hydatid cyst, and the round pneumonia. Of course, you know that tuberculoma and hamartoma are benign lesions that contain calcium. They usually show smooth margin and internal calcification. And if you see a lesion like this in the apex of the lung or in the upper lobe with a smooth margin and there is internal calcification in a child or in an adult, you can say safely that you are dealing with a tuberculoma. But in the pediatric patients, we have other stigmata that are helpful in the diagnosis, and we all know what is known as the primary TB complex in the pediatric chest. In this complex, we have three pathologies, which are the pulmonary lesion, lymphangitis, and lymphadenitis. And this lesion, it can be easily diagnosed in the pediatric chest, where you can see a lesion in the lung, whether nodule or a consolidation, and as this lesion is associated with mediastinal lymphadenopathy. And the nodes in TB are usually necrotic. They contain hypodense center with peripheral enhancement, and they may show internal calcification. And this is a good example in a child 6 years old. You see, this is the arch of the aorta, and this is the superior vena cava, and this is an enlarged retrocaval lymph node. You remember that this is the normal thymic gland. In here, you see a nodule in the lung, and this nodule is what we call the Gonz focus, or the pulmonary component of the TB primary complex. And you see mediastinal lymph nodes, which are necrotic, typical of TB. Then the lesion, this is also another example. You see here a pulmonary nodule in the middle lobe, and you see nodes, the prevascular lymph nodes, the retrocaval lymph nodes. These nodes are containing calcium, and this is one of the supportive diagnostic criteria for tuberculous lymphadenopathy. Then in a child, if you see a pulmonary lesion, whether it is in the form of consolidation, like this one, with air bronchogram inside, as well as mediastinal lymphadenopathy. This is the aorta, this is the superior vena cava, retrocaval lymph nodes, prevascular lymph nodes. Then you may think of TB primary complex. And this is a golden rule. TB primary complex should be considered in the differential diagnosis of mediastinal lymphadenopathy in the pediatric age group. That is to say, if you see a pediatric chest and you can see that there are mediastinal lymph nodes, mediastinal lobulated masses in anatomic sites, of lymph nodes, then one of the differential diagnoses should be a TB primary complex. Then the hamartoma is a benign lesion made of normal cells arranged in abnormal location. And the hamartoma being asymptomatic, it is usually seen in the adult patients and less frequently seen in the pediatric cases. And this is an example of a pulmonary nodule which is located in the left lung base. But if you have the chance to see calcium inside the nodule, then you are in the differential diagnosis of the tuberculous lesion, the tuberculoma, or the hamartoma. And we used to make the differential diagnosis in adults based on the location of the nodule. If it is in the upper lobe or in the ABCs of the lower lobe, then we consider it tuberculoma. But if it is located in the lung basis, then we say that this is hamartoma. But in the pediatric age group, you can easily separate between tuberculoma and hamartoma based on the fact that tuberculomas are usually associated with mediastinal lymphadenopathy in the pediatric patient, forming the well-known TB primary complex. Then if you see a lesion like this one, which is in the form of a nodule with a smooth margin containing calcium, not associated with enlargement of the mediastinal lymph nodes, and you may think that this should be a hamartoma. And you know that this is the arch of the aorta, and this is the superior vena cava, and this is the thymic gland. Then we came to the next nodule, which is the metastatic deposits. Of course, we diagnose metastasis by the positive history of a known primary malignancy. And in this case, we can see multiple nodules scattered throughout the lung fields. And this finding in adults and also in the pediatric patients is suggestive of metastatic disease, even if we don't know that the patient had a primary malignancy. But if we know that there is a primary malignancy, this will support the diagnosis. Like in this case of a child with a known osteosarcoma, then you can see numerous pulmonary nodules scattered throughout both lung fields, representing metastatic deposits. And this is the case of Wilms tumor. You see a big tumor in the left kidney, in the right kidney, and this tumor has given metastatic deposits to the lung in the form of multiple pulmonary nodules. Then this female child has an adrenocortical carcinoma, and her chest CT shows numerous pulmonary nodules scattered in both lung fields, representing metastatic deposits. The next nodule seen in the pediatric age group and also in adults is the pulmonary arteriovenous malformation. And the arteriovenous malformation is a nodule which is connected to the hilum by two cord-like structures. And these two cords represent the arterial supply and the venous drainage of the vascular malformation. The usual size of the vascular malformation is in the range of 1 to few centimeters, and it does not contain calcium. The presence of a vascular pedicle is very important for the diagnosis of pulmonary arteriovenous malformation. And you can use the CT facilities to perform CT pulmonary angiography, and also you can reconstruct the images in a 3D way. Then you can see the pulmonary arteriovenous malformation, and you can see the feeding artery and the draining vein, and this is helpful in the diagnosis of a vascular malformation. And in this patient with multiple pulmonary arteriovenous malformation, which are usually seen in the course of this disease, which is known as hereditary hemorrhagic telangiectasia. And if you look here in the chest X-ray first, then you can see a nodule in the right lung, and this nodule is connected to the hilum by what looks like a dilated vessel. And the CT scan showed the nodule in the right lung and is connected by a prominent vessel to the hilum. And it's very important to know that you may be able to see only one of the two cords going to the nodule, and this is enough for the diagnosis. It is better to see the arterial and the venous drainage, two cords, but if you see only one, and this is enough for the diagnosis of arteriovenous malformation, because the second cord may not be shown in the same section. It may appear in the previous or the next section. Then you see this is an arteriovenous malformation in the apex of the lower lobe. You remember the tracheal bifurcation. This is the upper lobe and this is the lower lobe. And this is the arteriovenous malformation which can be seen here. But if you go down and you see another one, and this is located in the middle lobe, and following the section, and you can see the remaining part of this pulmonary arteriovenous malformation. Also, this CT scan shows a nodule and a prominent vessel adjacent to the nodule. And by selective pulmonary angiogram, you are able to see the feeding artery, and if you wait for some time, you will see the draining vein. Then the pulmonary arteriovenous malformation, when it is multiple, you know that this disease is known as hereditary hemorrhagic telangiectasia or is Osler-Weber-Rendoux syndrome. And then in this case is be represented by hemoptysis, and here in the plain X-ray you see an arteriovenous malformation in the right lung base, which is well demonstrated on this CT section. And if you look carefully, you can see another one in the left lung base. The presence of multiple pulmonary arteriovenous malformations is highly suggestive of this disease, which is known as Osler-Weber-Rendoux syndrome or hereditary hemorrhagic telangiectasia. I have said that if you see a nodule which is connected to the hilum by a vascular pedicle, then you think that this is an arteriovenous malformation. Sometimes the vascular pedicle cannot be seen in the same section of the pulmonary arteriovenous malformation. Then you may have the facility of multi-detector CT, and you have sections along the course of the vascular pedicle. Then you will have this image, which is a coronal oblique showing the pulmonary arteriovenous malformation connected to the hilum by the vascular pedicle. And of course, if you are not able to inject the patient of contrast because of his bad renal function or because of his hypersensitivity to contrast media, then you may have the alternative, which is the MR angiogram. And this is an example of a pulmonary MR angiogram. And you should know that the MR angiography is not performed using contrast media. It is performed using the motion of the blood in the vessels. Then you see a big arteriovenous malformation here with a smaller one nearby, and there is also a big one, and you see this is the feeding artery and this is the draining vein. Multiple arteriovenous malformations are suggestive of Osler-Weber-Rendoux disease. The next nodule is the hydatid cyst, and I usually believe that the only water-containing lesion in the lung is the hydatid cyst. So if you see a nodule or a mass totally containing water, and it is located inside the lung, and you may think that you are dealing with hydatid cyst. And frequently in the pediatric age group and also in adults, you can see other hydatid cysts in the liver or in the spleen. And this is the difference between the lung abscess and the hydatid cyst. The hydatid cyst is usually uh, having a very thin margin, which it does not enhance with contrast media, while the abscess has a thick margin, which enhances with contrast injection. And very frequently, you can see air loculi within the abscess, and whenever you see air, and this is no more a nodule or a mass, it is a cavity, and we'll discuss this in details after that. Then the last nodule in this category is the round pneumonia. And round pneumonia is frequently seen in the pediatric age group compared to those in adults. And most of the patients, about 90%, are younger than 12 years old. It's very important to know that this one of the lesions seen in the pediatric age group, so that you cannot jump for the diagnosis of other pathologies, or you can go for further imaging like by CT, for example, if you have the clinical data which are adequate in the form of the signs of infection, fever and the cough, and the rounded lesion in the lung, whether it is in the size of a nodule or in the size of a mass. Then if you are going to diagnose round pneumonia, you should know that this lesion is caused by bacteria and is treated by antibiotics. Then the causative organism is the pneumococcal or the staphylococcal according to the literature. But if you see the clinical data and you see a lesion which is suggestive of ground pneumonia, then you can go directly for antibiotic therapy. And the follow-up after 4 days showed total clearance of the lesion. Ground pneumonia will clear in the range of 1 week, and it will change in the size and the appearance in response to the antibiotics. This is the male child, 4 years old, with a round lesion in the right lung, and this is the follow-up after antibiotic therapy with total clearance of the lesion. Then you should know that round pneumonia in most of the cases is a solitary lesion, and in any case of pneumonia, you should see some air bronchogram within the lesion in the form of uh, a branching radiolucency representing air-filled bronchi, but in my opinion and according to the cases I have seen, the air bronchogram is not a prominent feature in this round pneumonia, and I think this finding is the cause of further evaluation by CT, for example, in such cases. And this is a case of round pneumonia. You see a lesion which is located in the lower lobe. Then you see you can appreciate the right cardiac border, meaning that this lesion is not adjacent to the heart, is not anteriorly located, is not in the middle lobe. Then you see the lesion in the lateral view located in the lower lobe. And this is in the course of or in the presence of fever and dyspnea, the signs of infection, then you are able to diagnose round pneumonia. You give antibiotics, and the follow-up chest X-ray showed total clearance of the lesion. Then we have finished with pulmonary nodules, and we discussed the possibilities of tuberculoma and the hamartoma, which are lesions with a smooth margin containing calcium, and the metastatic deposits, which are usually multiple and need the clinical data of the presence of a known primary malignancy. The hydatid cyst is a rounded lesion containing water inside the lung parenchyma, and I have mentioned the difference between hydatid cyst and the abscess. Pulmonary arterial venous malformation is a nodule which is connected to the hilum by a vascular pedicle made of a feeding artery and a draining vein, but many times you can see only one of the chords of the pedicle and not the other. And finally, the round pneumonia, which should be considered in the differential diagnosis of pulmonary nodules and pulmonary masses in the pediatric age group whenever the clinical data are suggestive of inflammatory lesion. Then we came to the pulmonary masses in I used to make this comparison between masses in adults and masses in the pediatric, and also nodules in adults and nodules in the pediatric age group. In adults, we have three main matches, which are the bronchogenic carcinoma, metastatic deposits, and the hydatid cyst. In the pediatric age group, we have the neuroblastoma instead of this bronchogenic carcinoma, but we still have the metastatic deposits and the hydatid cyst, and we should add the round pneumonia in reliable clinical settings, as I have mentioned. Then we came to the masses in the pediatric age group, and we emphasize this issue, which is the pulmonary neuroblastoma. And here you see a big mass in the right lung displacing the heart to the right side. And one of the policies in order to reach the differential diagnosis is just to try to know if this mass is containing fluid or not. Because if it is containing fluid, it will be a large hydatid cyst. But if it is solid and you think of pulmonary neuroblastoma, then One of the best ways to have this information is to do a chest ultrasound. And this chest ultrasound is very, very good in the pediatric age group, considering this differential diagnosis. You know that ultrasound is free of radiation. Ultrasound is cheaper than CT scan. Ultrasound do not need the injection of contrast material, and the ultrasound can be performed as a bedside technique. Then it is a reliable diagnostic way to separate the solid from the cystic masses. And if you know that this mass is solid, then you know that in the differential diagnosis, you should include the possibility of neuroblastoma. And the neuroblastoma is usually presenting at or below the age of 3 years, and it is located usually posteriorly in the paravertebral gutter and is considered a mass in the mediastinum, not actually in the lung. And you know that it can also arise from the adrenal gland. Then frequently the mass contains calcium, and calcium is seen by CT in about 85% of cases. And these masses also being of neurogenic origin, they may extend inside the spinal canal. Then in 85% of neuroblastomas show calcium, but by CT. You know, CT is much more sensitive than X-rays for detection of calcium. About 30% of neuroblastomas are not MIBG evident, and this is the radioisotope, which is was used before for the detection of neuroblastoma whenever you are suspecting this disease. Then the neuroblastoma may present with the paraneoplastic syndrome, including other manifestations in the human body. And what is very important here is to know that the neuroblastoma may mature to ganglioneuroblastoma and then to the adult form of ganglioneuroma, which is a benign lesion. This is a malignant lesion, an intermediate lesion, and a benign lesion after that. Then here you see a mass in the posterior mediastinum in the paravertebral gutter. The mass is here. This is the mass which has displaced the heart and the mediastinum to the right side. And if you have the CT scan, and you see this is the mass which is not enhancing, showing almost homogeneous pattern of contrast enhancement, and many times you can detect calcium within the lesion. And this is a big neuroblastoma. And here you can see this mass in the lateral view. You can see also the mass in the CT scan axial images. The mass is solid, containing calcium. And in the coronal reformatted image, you see the mass which is almost similar to that of the chest X-ray, displacing the heart and the mediastinum to the opposite side. Then and this is a case also of neuroblastoma, and you see this mass, and in the CT scan you easily appreciate the presence of calcium, and also you can see the extension inside the spinal canal. MRI may be used for evaluation of thoracic neuroblastoma, and the main values of MRI is to see the intraspinal extension and compression of the cord, and this is a big mass on the left side, which is not extending inside the spinal canal. This is the cord surrounded by regular CSF. Then these are the neurogenic tumors, starting by the neuroblastoma, which is seen below the age of 3 years, the ganglioneuroblastoma, which is an intermediate form seen in the age of 3 to 10 years, and the ganglioneuroma seen in the age above 10 years old, and finally the schwannoma and neurofibroma, which are benign lesions seen in adults. Then this is a ganglioneuroblastoma in a male child, 4 years old, and you see it is almost exactly similar to the neuroblastoma, a posterior mediastinal mass in the paravertebral gutter, and it contains calcium. And Actually, the age of the patient is not a clear-cut differentiating point between the lesions, but the final diagnosis is left for the biopsy. Then, in my opinion, if I see a CT scan like this with this mass, I will say that I'm dealing with a neuroblastoma. Then, if you have a biopsy from this lesion to confirm or to know the cell type of the lesion. Then ganglioneuroma is the benign form of the tumor, which is seen in patients older than 10 years old. The neuroblastoma is seen in patients younger than 3 years old. Ganglioneuroblastoma is seen in between these two, between the age of 3 and the 10 years old. But ganglioneuroma has a less incidence of calcium matrix calcification, which is in the range of 20% compared to the neuroblastoma, which contains calcium in about 85% of the lesions. Then this patient is presenting with cough and dyspnea, and the chest X-ray showed a mass in the upper part of the chest, and the CT scan showed the mass containing calcium. Then, considering the age of the patient, you should diagnose that this is a neuroblastoma. But based on biopsy finding, this was found to be a ganglioneuron. And this is a female child, 12 years old, and this age is good for the diagnosis of ganglioneuroma. There is a mass which is located posteriorly. You can see the cardiac border through the mass, denoting that this mass is posterior to the heart, and in the lateral view, you see the mass posterior to the heart. And this is a ganglioneuroma of the same case by CT and by MRI T1 weighted image after contrast, and this is also T1 weighted image after contrast in the coronal axial and the coronal T1 post contrast. Then the second mass in the pediatric age group and also in adults is hydatid cyst, and hydatid cyst is diagnosed by its fluid content. And you see here multiple large masses in the chest, and the CT scan showed or the ultrasound will show the water content of the lesions, denoting that you are dealing with hydatid cysts. And this is also a good example of a hydatid cyst containing fluid in the left lung of a child 5 years old. And this is a child 7 years old showing a mass in the apex of the left lung. The CT scan showed that the mass is containing fluid, denoting the presence of hydatid cyst. And this is a mass containing fluid in the right lung, representing hydatid cyst. And this is the chest X-ray showing a big mass in the base of the right lung by CT, and you see that there is fluid inside the mass, diagnostic of hydatid cyst. Then metastasis can appear in the form of micronodules, miliary shadows, or in the form of nodules, or in the form of masses. And the diagnosis is based on the presence of multiple lesions as well as the known primary malignancy. In this female child, they see she has an osteosarcoma with multiple variable sized masses and nodules scattered in both lung fields, representing metastatic deposits. And in this male child with a known Ewing sarcoma, there is a mass in the left lung, and you should diagnose this mass as metastasis if you know that the patient had a primary malignancy. And this is also a case of osteosarcoma with a big metastatic deposit in the right lung. And metastases which are sizable are called the cannonball metastatic deposits. Then you remember that one of the differential diagnoses of pulmonary nodules and masses in the pediatric age group is round pneumonia, especially if you have a positive finding of infection. You know that round pneumonia is usually seen in children under the age of 12 years. Whenever you are going to diagnose this, you know that this is bacterial infection and it is usually treated by antibiotics. The size of the round pneumonia ranges from 1 centimeter up to 7. The 1 centimeter is a nodule and the 7 centimeter is a mass, and the follow-up chest X-rays will show clearance of the mass after antibiotic therapy. Then this is a good example of a round pneumonia in the form of a mass in the apex of the right lung, and this is also a good example of a round pneumonia in the apex of the right lung. Thank you very much. Alhamdulillahi Rabbil Alameen.